So we're going to go over the chest and lungs checkoff today, and starting out with the patient positioning. So from the posterior aspect, when you inspect and palpate, you're going to have the patient lean forward and cross his arms. Again, that moves the scapula out of the way so you can, when you auscultate and percuss, everything is going to be over the open lung fields there. So you're inspecting the chest wall posteriorly, looking for symmetry. Then I'm going to move and do the lateral positioning. You're going to have them raise their arms up over their head so you can see the axillary region on both sides. And then when you're anteriorly, you're going to have them sit straight up with their arms out to their side like this. So with inspection, you're looking for evidence of barrel chest. You're looking at that AP diameter, looking for any lesions, abnormal venous patterns, any asymmetry. You're looking at the trachea midline, and we're going to start with the landmarks as we palpate as well. You're going to palpate that trachea, make sure there's no tugs or asymmetry there. And then the suprasternal notch, we'll feel that area right there. And then as we move down over the manubrium, we'll feel that angle of Louis, which gives us the second rib right here. If you need to count the ribs down like that. And then moving down, we'll see the costal angles where the ribs come up and meet in the front. That should be about a 90-degree angle right there. Then we're going to move posteriorly for the landmarks back here. Have you lean forward and tilt your head down. You'll see the high point is C7 right here, and just below that's going to be T1. So whenever you see two prominent areas, the highest one's going to be C7. At the lower end of the rib cage is, if you follow the ribs up, they're going to meet, and that's going to give you the T12 vertebrae. Okay, again, palpating all the areas anterior, posterior, and lateral for tenderness, any crepitus, nodules, masses, or any abnormalities in that nature. Also, you're going to do what's called tactile fremitus. So your vibratory sense is best detected by the ulnar surface of your hand. So I'm going to have you say Mickey Mouse.
Mickey Mouse.
And I'm feeling for the vibration from the phonetics in both lung fields. I'm feeling for symmetry. Mickey Mouse.
Mickey Mouse.
Mickey Mouse.
Mickey Mouse.
And so areas of consolidation are going to have more vibration. So it would be asymmetric. If there's consolidation in that upper area of the lungs, you would feel it stronger in the area of consolidation. Thoracic expansion. So I'm going to go right about that T12 level and spread my hands out here and have them take a deep breath in and out. And you can see my hands are moving away from each other symmetrically. Once again, deep breath in and out. So that shows symmetric chest wall movement. Okay, from the anterior aspect, again, you're going to look for any abnormal anatomy of pectus carinatum or pectus excavatum. I'm going to have him stand up, and again, looking for any kyphosis that may be occurring. Turn sideways to the wall that way. And we're going to look for any scoliosis or curvatures, kind of lean forward a little bit. If there's scoliosis and a rotational deformity, you'll see one shoulder higher than the other, sort of a hump back there. Okay, stand up straight again, very good. And you see that the spinal alignment is normal there. Okay, we'll have you sit back up here again. Okay, now we're going to begin percussion. So I'm going to have you lean forward, cross your arms. And we're going to start up in the area of the highest point of the ribs up here. And we're just listening for that resonance in there. And we're comparing side to side. And we're going from superior to inferior and medial to lateral. And the further we get down here, the further out lateral we'll get over those sides. And so those are all the areas that we percuss are going to be the same areas that will listen when we auscultate. One further test with percussion we're going to do is called diaphragmatic excursion. So the diaphragm is below the lungs. When you breathe in or inspire, that diaphragm is going to move down. So you're going to have the patient take a deep breath in and hold it, and that's when you're going to percuss all the way down. You hear resonance, and you'll percuss down till you hear dullness. So take a deep breath and hold it. When that starts to flatten out, you're going to mark that area, and that shows you can breathe out. And that shows you where the diaphragm went down to. Now I want you to take a deep breath and blow it all the way out and hold it out. And we're going to percuss. And so the area where it gets dull is going to be above the area, and that's called your diaphragmatic excursion. You're going to check that on both sides for symmetry. It may be a little bit higher on the right side because of the liver underneath the diaphragm. But what you want to see is a symmetrical movement on both sides of that diaphragm with inspiration and expiration. And then to percuss laterally, so raise your arms up over your head. We'll start here. You hear that resonance. Make sure you go anteriorly over that middle lobe on the right side. Okay, lower your arms, and then you can percuss up at the apex. Infraclavicular. Above the breast tissue and then below. And if you have a female, you'll have her raise her breast up out of the way. You should have a chaperone in the room with you. Okay, so that's percussion. Now we're going to move to auscultation. Same thing, I'm going to have you lean forward, cross your arms again. And our listening areas are the same areas that we percussed. So every time I move my stethoscope, I'm going to have you take a deep breath in and out, and we'll do nice slow cycles so the patient doesn't hyperventilate. Take a deep breath in and out. Good. And you're going to listen to that whole cycle. You just take your time going through this, listening to that complete cycle of respiration. And again, you're going to hit all of the, I'm going to move quickly through these, but you're going to hit all of the areas of listening that we did palpation. And then doing the lateral aspect, raise your arms over your head. We'll start in the axillary area. Listen to this side, in and out. And this side, in and out. Remember to get that anterior aspect around that 5th or 6th rib area for that middle lobe. And here on that side. Okay, you can lower your arms. You want to listen up at the apex up there. Good. Okay, and then periodically you want to take a break so they don't just keep breathing over and over. But all of the same areas that we percussed, we're going to listen. And again, here, 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 and here. Another thing is, as you're inspecting and when you're taking the patient's pulse during your physical exam, you're going to count that for 30 seconds, multiply by 2, and then for the next 30 seconds, you're going to watch the rise and fall of the chest wall to get the respiratory rate. So you're not going to tell them that you're taking their respiratory rate, because patients will alter their breathing patterns normally when you do that. So you're going to just listen 30 seconds. Watch the chest wall rise and fall, and then you're going to multiply that by 2, and that's going to give you your respiratory rate. And finally, we're going to go to sounds, bronchophony and whispered pectoriloquy. Lean forward, cross your arms. So again, over areas of consolidation, you're going to have amplified sounds. So we'll have them say Mickey Mouse.
Mickey Mouse.
Mickey Mouse.
Mickey Mouse.
If this is an area of consolidation, this is going to be louder, amplified more. Whispered pectoriloquy is the same dynamic. It's just I'm going to have them whisper,
Mickey Mouse.
and it's still amplified compared to another area.
Mickey Mouse.
And that just tells you that there's a significant area of consolidation there, or a solid mass. And then finally, we're going to do egophony, where I'll have them say me,
Me.
me,
Me.
and over an area of consolidation, the E would sound phonetically like an A. All right, that completes the chest and lungs checkoff.